Hello. In this part from the adult congenital heart disease, we will go through the pathophysiology of cyanotic congenital heart disease. I'm Sahar Omeh. I'm a consultant of adult congenital heart disease. I'm from Egypt. First, we will start by the definition of the cyanosis. We will concern about the central cyanosis. And central cyanosis occurs when the arterial oxygenation decreased and the concentration of the oxyhemoglobin is more than 5 gram per deciliter. When we have a patient with central cyanosis, this indicates a cardio or pulmonary condition. Cyanotic heart disease, we could classify that by many classification, but I find this classification is very useful in clinical practice. We can classify them into 3 different types: the right heart obstructive lesion, left heart obstructive lesions, and mixing lesions. Etiology of cyanotic congenital heart disease is not actually known. It might occur in isolated and sporadic, but when it's associated with genetic syndromes, we have between 15 to 20 infants with cyanotic congenital heart disease are well known to related to chromosomal abnormalities: trisomy 21 and 13 and 18 and Turner syndrome. There are 2 tests. They are very useful in the outpatient clinic when you deal with cyanotic congenital heart disease. The first one is pulse oximetry screening. It's very easy, and after COVID pandemic, actually all the clinic have this pulse oximeter. So in the pulse oximeter for cyanotic congenital heart disease, it's have been added to the recommended uniform screening by the United States in 2011 and also by the American Academy of Pediatrics in 2012. You consider that the pulse oximeter screening is positive in the following condition. Usually we measure it in one arm and one leg. So if you find any oxygen saturation below 90%, or when the oxygen saturation is between 90 and 95 in both arms for 3 measurements apart from each other by separated by 1 hour, or when we have more than 3% absolute difference in oxygen saturation between the upper limb and lower limb, also in 3 measurements apart from each other by 1 hour. Positive pulse oximeter screen require further action, including measurements in the blood pressure in the 4 limbs and the chest X-ray, ECG, and the echocardiography. This is the first simple clinical test in outpatient clinic, the pulse oximetry screening, and the second one is the hyperoxia test. Hyperoxia test, it's an initial method to distinguish between if the central cyanosis is due to the heart or the lungs. It is cardiac condition or pulmonary condition. The test is very simple. It's measuring the arterial blood gases at room air and as first step, and then give 100% of oxygen for 10 to 20 minutes. If the patient have increase in the oxygen saturation after giving the oxygen, it means that this is a chest condition. If the patient is not able to increase the oxygen saturation after giving the oxygen administration for this period, so it means it's a cardiac condition. So the patient who have a positive results, it is a cardiac origin, and we should go also for cardiac workup for this cyanotic congenital heart disease. So again, to recap, we have 2 tests, the pulse oximeter test and the hyperoxic test. Back again to our classification, that cyanotic congenital heart disease can be classified into these 3 forms. We will start by the first one, the right heart obstructive lesion. So the right heart obstructive lesion, actually it's wide range. So we start with the tetralogy of Fallot from the first of the scale to the extreme degree of the tetralogy of Fallot at the end of the scale, pulmonary atresia and VSD, critical pulmonary stenosis, and tricuspid atresia. All of them are right heart obstructive lesion. The pathophysiology of this group lead to decrease in the pulmonary blood flow because it's right-sided obstructive lesion. Therefore, the BDA will supply the pulmonary blood flow. We call it duct-dependent pulmonary circulation. And inside the heart, if the patient have an PFO or VSD, the shunt will be right to left in this intracardiac shunt. So again, to recap, it's decrease the pulmonary blood flow, and we have to have an origin for this blood supply to the pulmonary. It will be the duct-dependent pulmonary circulation, and inside the heart, all the shunts, intracardiac shunt, will be right to left. If we do the screening finding, we will find the pulse oximeter test is positive, with oxygen saturation is lower than 90% without any difference between oxygenation in the upper and lower limb. Hyperoxia test will be positive, and chest X-ray will show oligemia or decreased pulmonary vasculature. This is the first group. The second group will be the opposite side, the left heart obstructive lesion. It could be hypoplastic left heart syndrome, interrupted aortic arch, critical coarctation, and critical aortic stenosis. The pathophysiology is this patient who had a left heart obstructive lesions will lead to decrease in systemic flow. Therefore, the duct will supply the systemic flow by shunting the blood from the pulmonary artery to the aorta, and we call this one is duct-dependent systemic circulation. There will be left to right shunt in the intracardiac shunt if the patient have PFO or VSD, and this will lead to the pulmonary over-circulation. So back to our screening test, we will find the pulse oximeter test positive with oxygen saturation between 90 and 95. There is a greater than 3% difference between the upper and lower limb. And we will find the hyperoxia test is positive, and chest X-ray will show the increased pulmonary blood flow or pleurothoric lung. The third group will be the mixing lesion. On top of the list is the TGA, transposition of great artery, and the TPPD, total abnormal pulmonary venous return, and the truncus arteriosus. The pathophysiology of this group, the cyanosis will be present for mixing the blood, the pulmonary and systemic blood flow, so it will be mixing inside the heart. This condition are considered duct-independent lesion. So in this condition, the duct will not support the pulmonary or the systemic circulation. BDA is not required, as it can be present with or without PFO. When we do the screening test, the pulse oximetry test will be positive with oxygen saturation less than 95. There is no difference between the upper and lower oxygen saturation, and the hyperoxic test will be positive. Chest X-ray show normal and or to increase the pulmonary blood flow depending on the condition. One of the famous conditions that clinician face in the outpatient clinic is cyanotic spells. Usually occurs with the tetralogy of Fallot, or whenever the RVUT, like we see here, have a subvalvular obstruction like that. The pathophysiology is the rapid decrease in systemic oxygen saturation with hyperventilation. Will lead to the convulsion and may be aggressive to the coma and death. Age is between 6 months to 6 years, usually not in the adult condition. Cyanosis will occur on crying is not a spell, and crying and exercise trigger this spell. The pathophysiology is drop in systemic vascular resistance, lead to the infundibular spasm, right to left shunt, acidosis, hyperventilation, and it will go to the visual circle. The treatment we should consider, cyanotic spell is an emergency. We help the patient to have a knee chest position to increase the systemic vascular resistance. We can help it by morphia and increase systemic vascular resistance with drug. Ventilation will help it, and we should consider this an emergency, an urgent case for surgery. And cyanotic heart disease could occur also in older patients or adults. And unfortunately, in our Arabic area, we still have a lot of Eisenmenger syndrome. The definition of Eisenmenger syndrome consists of 3 fundamental parts. It's irreversible pulmonary hypertension. It's irreversible at or near systemic level with reversed or bidirectional shunt between the pulmonary and systemic circulation. and pulmonary vascular resistance should be more than 10 Wood units as a T. Eisenmenger have been discovered in 1997 by Victor Eisenmenger. It was an Australian physician and described the Eisenmenger syndrome as postmortem details in adult young gentleman. He was 32 years and he has an VSD with cyanosis. And the evolution of Eisenmenger syndrome, that we have intracardiac shunt that acyanotic, like an ESD or VSD or BDA, that will lead to the aggressive left to right shunt, will lead that the lung will be congested and plethoric. Then by the time the lung will try to protect itself, it will lead to the vasoconstriction in the lung vessel, in the pulmonary vessel. At that time, still reversible, but if this shunt is neglected for more time, it will lead to the irreversible vasoconstriction in this blood vessel, and it will lead that pulmonary vascular resistance will be much greater than systemic vascular resistance, and the shunt will be reversed and lead to cyanosis. So Eisenmenger syndrome is a progressive condition. So we started by left to right shunt until the cyanosis right to left shunt by this Eisenmenger syndrome. And as I said, it's reversible pulmonary hypertension. Eisenmenger syndrome, to be documented, it should be documented, as we said, it's irreversible. So we have to do by cardiac catheterization. This is the only way to do it. And we have to measure the pulmonary vascular resistance at rest and give a potent pulmonary vasodilator like oxygen or nitric oxide if it's available, to document that this pulmonary vascular resistance, the high one, is irreversible. And usually in this catheterization, we don't need to use contrast. So Eisenmenger syndrome, the only way to coin the diagnosis is to do invasive cardiac catheterization. Otherwise, many patients will be deemed to be an Eisenmenger syndrome without an accurate diagnosis. Eisenmenger syndrome is not a congenital heart disease, it's a pathophysiological condition. Eisenmenger syndrome, keep it in mind, it's preventable. It's preventable if we could detect the patient in the correct time. Okay, back to the clinical. All cyanotic heart disease, the three groups and the Eisenmenger, we have to understand that because the patient is cyanotic for a long time, they will have to have an expected pathophysiological adaptation. What these adaptations are, that life-sustained hematological adaptation to their chronic cyanosis will have a risk of adverse consequences on that to keep the patient at balance. We will recognize long-term complication of cyanotic congenital heart disease and with this clinical manifestation. The first adaptation that we have for this low oxygen saturation, that we have secondary erythrocytosis. It's described as physiological consequences of increased RBC's mass to improve the oxygen delivery. Maintenance of the steady state of hemoglobin and the RBC's function for a given oxygen is thought as optimized tissue delivery of oxygen. This steady state is called compensated erythrocytosis. So if we ask ourselves, what is the relation between hemoglobin and oxygen saturation should be? So the hemoglobin was related to the oxygen saturation in that formula, that predicted hemoglobin equal to 61 minus oxygen saturation divided by 2. If the patient have an oxygen saturation of 70, if we did this calculation, the predicted hemoglobin for this specific patient should be 26, not 10, not 11. So we should expect the patient to have a higher hemoglobin if they are cyanotic. They further found that the patient with hemoglobin below the calculated or predicted hemoglobin, they have the worst VO2 after 6-minute walk test, and the deviation of the patient from this ideal hemoglobin is affected his exercise capacity. Secondary erythrocytosis will have consequences, as we said. The three consequences that secondary erythrocytosis have is hyperviscosity, iron deficiency, and coagulopathy. The first one, hyperviscosity, the secondary to erythrocytosis, it will lead to massive increase in the RBC's mass. Symptoms will be headache and visual changes and muscle ache and fatigue. Iron deficiency anemia, the patient will be symptomatic and this contributed to the compensated in erythrocytosis and will give a dangerous feedback on top. Coagulopathy can develop both bleeding and thrombosis, and keep in mind that all cyanotic patients have a false high NR because they have massive increase in the RBCs, and actually the INR does not represent the coagulopathy profile of those patients. Management of hyperviscosity, it had been for long time that we will like to decrease the RBC's mass. Phlebotomy or vein section to remove the RBCs and keep the patient hydrated, either by oral or parenteral fluid administration. The second one, we keep it that we have to keep the patient as they are for hydration, but the phlebotomy have been changed. In the recent guidelines, it was from 2013, that American Heart Association keep the phlebotomy or vein section as class 2A indication only in two conditions. If the patient have a hyperviscosity symptoms and the hematocrit is more than 65%, with no evidence of iron deficiency anemia, because both of them will give the same symptoms, patient undergoing non-cardiac surgery when the hematocrit value is more than 65. Otherwise, phlebotomy is not indicated in those cyanotic patients. Iron deficiency anemia evaluation, we should keep in mind that mean corpuscle volume and the mean corpuscle hemoglobin concentration does not reflect the iron deficiency in those cyanotic patients, because the cyanosis will lead to the macrocytic increase the size of the RBCs. So this does not represent the iron level in those patients, but transferrin saturation is the indicator of the iron level of this patient. If the transferrin saturation is lower than 20%, this is an indication for iron replacement. How to measure the oxygen saturation in those patients? Actually, in those patients will be clubbed by in the upper and lower limb. This clubbing, it's a proliferation of the tissue, and this could handle the measurements of oxygen saturation. So it's advisable to measure it in the ear loop or in the soft tissues, just to get the correct measurements of the oxygen saturation. The other systems that will be affected from these consequences of the secondary erythrocytosis, the brain will be affected by hyperviscosity, either stroke or TIA. The patient might have a cerebral hemorrhage due to the inadequate coagulopathy profile. And if the patient have right to left shunt, he might have an paradoxical embolism or brain abscess. What we should do for that, we should use air filters for or intravenous access line. Cerebral imaging for any new headache or neurological signs is recommended in their patient to exclude having a cerebral abscess. The lung will be affected because the pulmonary artery thrombosis could be causing lung infarction and lead to hemoptysis. Kidney is affected in both conditions. Hypoperfusion due to the hyperviscosity, which lead to the renal dysfunction, or decrease in the renal clearance of uric acid, and this will lead to the hyperuricemia. Keep in mind that all cyanotic patients complain from symptoms like gout, so you have to check the uric acid for those patients regularly. Liver and gallbladder, due to the increase of erythrocytosis, it will lead to increase in RBCs desaturation and the unconjoined hyperbilirubinemia, and this is a risk factors to accumulate gallbladder stones. So our recommendation, without exceptions, all patients with cyanosis should have a yearly visit with an experienced congenital heart center. Resting oxygen saturation on room air measured and at rest and after 6-minute walk test. For the labs, hemoglobin and the hematocrit, transferrin level, uric acid, and appropriate measurements of INR using straight-adjusted phlebotomy tubes is recommended. Coronary artery disease is rare in this group because the lipids are usually low and of little values to have a regular lipid screen. All patients deserve a baseline ECG and chest X-ray. Imaging should be done on occasion to assess the biventricular function if you have any doubts about the function. The conventional therapy for orthocyanotic patients, all of them should be on infective endocarditis prophylaxis. Consider any IV line as an arterial line. Non-cardiac surgery specialized centers should be available. Avoid dehydration either by oral or parenteral hydration. Avoidance of acute exposure to heat and avoidance of pregnancy, as it's well known that maternal mortality is 30% in this group. Still, we have a question mark about oxygen home therapy and anticoagulation. For oxygen therapy, the long-term home oxygen therapy may improve symptoms. No survival benefits about it yet. It's recommended to improve in saturation and symptoms as class 2 AC. However, we should keep in mind that adverse effect of mucosal dryness leading to the mucosal bleeding and should be avoided in those patients. So, in bottom line, oxygen therapy is just to improve the symptoms and no survival benefits yet about it. Anticoagulation is a big controversial issue about it. That those patients have really abnormal coagulopathy profile. They have a high incidence for pulmonary artery thrombosis and stroke, and stroke versus high evidence of bleeding and hemoptysis. We should say that in absence of significant hemoptysis, oral anticoagulation treatment should be considered in those patients who have pulmonary artery thrombosis or sign of heart failure. This is ECC guidelines. It's level 2A, level C. The last thing that I would like to demonstrate in my presentation, the types of pulmonary hypertension in congenital heart disease. The Eisenmenger is not the only increase in pulmonary hypertension. Actually, we have 4 types about it. It's preoperative pulmonary arterial hypertension. So, as we said, that left to right shunt lead to the pulmonary congestion, and the lung will start to be show some vasospasm in the pulmonary artery, but at the same time, it's still reversible. And we can have an acute postoperative pulmonary arterial hypertension, that pulmonary crisis that occurs in the neonatal ICUs. And we can have a chronic postoperative pulmonary arterial hypertension. This is actually one of the most difficult one to detect. If the patient have a shunt and it had been closed accurately, but after that, for unknown reason, the patient will have a chronic progressive pulmonary arterial hypertension after closing of the shunt, and this will lead to the right-sided heart failure. And the fourth one is the Eisenmenger. So actually, we have 4 types of pulmonary arterial hypertension in congenital heart disease. It's preoperative pulmonary arterial hypertension, or acute postoperative pulmonary hypertension crisis, or chronic progressive postoperative pulmonary arterial hypertension, and the last one is the Eisenmenger as we defined it before. Thank you all. That was an introduction for pathophysiology for cyanotic congenital heart disease. In the advanced course, in the adult congenital heart disease, we will go through more of them. Thank you all.